So in this talk, I'm going to be going into depression in older persons, otherwise known as late life depression. I've included 3 references for you at the bottom of this first slide, and I'll be referring to them throughout the presentation. So it would be worth your while trying to collect these references. To start off with, I'm going to discuss a real-life case with you, a man called Patrick who came to see us a few years ago, and his case illustrates some interesting points of late life depression, which I think will be worth thinking about as we go through the talk in more detail. So Patrick was 69 years old. He was previously high functioning, but had lost his business and in the process also a lot of money. So the family had been experiencing a lot of financial stress. By the time he got to us, he'd been depressed for about a year and expressed symptoms of hopelessness, guilt. He'd become agitated and highly anxious. In addition to this, he showed features of at least mild cognitive impairment with a mini-mental score of 26 and a MoCA score of 21, and he had some impairment of executive functions on the MoCA. He'd been on various drug trials, including mirtazapine, quetiapine, paroxetine, and venlafaxine. And throughout his treatment, he complained bitterly about having a dry mouth. The workup was normal, apart from the CT scan of his brain, which showed diffuse mild white matter disease. He spent 2 months with us on the G22 neuropsychiatric unit, and I'll come back to Patrick at the end of the presentation. Regarding the epidemiology of late life depression, one of the review articles talks about a 1 to 4% point prevalence in communities or community samples of major depressive disorder, whereas other types of depression, milder forms, are at least 3 times more common, in the region of 4 to 13%. Bearing in mind, of course, that depression increases with age and is much more prevalent in medical settings like hospitals and, of course, nursing homes and care centers. People who find themselves in some form of long-term care have a very high point prevalence of any kind of depression, be it minor or major. From a quarter to a third of them will complain of it. The trajectory of depression in late life is highly variable, as it is in younger persons. There are a group of people who develop mild symptoms and may grumble along or even recover. There's a group who develop depression in late life, and we'll talk about those just now. There are those who have a relapsing, remitting type of depression. They'll make good inter-episode recovery. And there are a group of patients who commonly come to psychiatrists or neuropsychiatrists with persistent and severe depressive symptoms. We do know, of course, that the severity and the persistence of depression is predicted by the comorbidity burden, in particular the medical comorbidity burden, but also by social isolation and inactivity. This is a model of late life depression that I would just like to talk through with you because it illustrates some of the complex interrelationships between predisposing, precipitating, and perpetuating factors. So in the first instance, you would have underlying vulnerability factors, starting off with heredity. So these are people who may have a family history of major depressive disorder or other mood disorders, who have developed major depression earlier on in their lives and developed it again in late life. There may be people who have psychological vulnerability, or otherwise known as temperamental predisposition. They might be neurotic, they might be anxious, they might be introverted, they might be people who tend not to find themselves supported and close to others. And then there are some anatomic vulnerability factors, such as abnormalities in frontostriatal circuitry. If you remember your fronto-subcortical circuits, the 5 of them, the Cummings circuits, 3 of those are behavioral circuits, frontal lobe circuits from prefrontal, dorsolateral, and mesial frontal circuits. And then, of course, the amygdala, which is an emotional response center of the brain, and the hippocampus, which is responsible for emotional and environmental information processing. All of these in the context of psychosocial adversity, which is commonly present in persons who develop late life depression, together with other age-related causal factors. Now we're talking about age-related brain changes, which could be things like neuronal loss, synaptic loss, disease-related changes as occur in inflammatory diseases or vascular brain disease, endocrine changes, and of course the immune system changes in persons who are older, and the allostatic response to adversity. So all of these factors, the underlying vulnerabilities and the causal factors, lead to a relative inability of the older person to adapt physiologically and psychologically to the stress that is placed before them. And of course, they then would be at risk of developing the depressive illness. And underlying this, one would then find these key mechanisms that might mediate the depressed state. So first of all, hypometabolism. This is a functional picture of dorsal neocortical structures. And you can just imagine our hypofunction of the cortex and the inability of people to rationally think through and manage and suppress subcortical or limbic emotional negative states might predispose them to and perpetuate depressive symptoms. And then hypermetabolism of the ventral limbic structures. So in this case, the adversity, the experience, the signaling from the environment and the stress circulates or reverberates through the limbic system and is unable to be mitigated or inhibited from higher cortical structures. Regarding the pathophysiology of late life depression, I've referred to dorsal neocortical structures being hypometabolic and ventral limbic structures being hypermetabolic in the previous slide. We also look at the cingulate cortex, which is responsible for motivation and drive in normal individuals, while disease of the cingulate leads to the akinetic abulic state. And so one can imagine that in persons with small anterior cingulate cortex volumes, they might be expressing apathy or depressed states, and this is in fact what is found. We also know that frontostriatal dysfunction can predispose to late life depression. We know that in the depressive phenotype of older persons, executive dysfunction is common. We also know that the group of subcortical disorders that compromise these pathways, specifically the movement disorder group, Parkinson's disease, Huntington's disease, and Parkinson's plus syndromes, are often, and more often than not, complicated by depression and executive dysfunction. We also know that these structures have low volumes in persons with late life depression. The amygdala is another brain structure that might predispose to depression throughout life, but particularly in late life. We know that the amygdala mediates emotions in response to aversive stimuli and is probably dysfunctional in traumatic states like PTSD, but may also be dysfunctional in perpetuating negative mood or affective states, such as in depression. And then we also referred earlier to hippocampal abnormalities in depression, and we know that the hippocampus is the cortical structure through which sensory stimuli and input from external and internal events is processed. And if the hippocampus is unable to process these experiences in a regular and routine way, to modulate them against earlier experiences and to receive inhibitory and mitigating responses from the cortex above, then you would have an abnormal affective state. Regarding late life depression, a few general comments. We know that a significant proportion of persons with late life depression have neurologic abnormalities, including vascular brain disease, degenerative brain diseases such as dementias or movement disorders, and even other abnormalities, physiologic abnormalities such as epilepsy or even traumatic brain disease. When we compare elderly individuals with early onset major depression, in other words, a true major depressive disorder of adult life, versus those individuals who have late onset major depression, the people with late onset major depressive disorder have a lower frequency of family history, so lower heredity factors. They have a higher prevalence of dementia. They have more psychological and neuropsychological impairment on testing. They have higher rates of dementia development on follow-up and more neurosensory hearing impairment. And this all goes to the idea that late life depression is either a prodrome or a feature of neurodegenerative disease and possibly even a precursor to Alzheimer's disease. We do face some challenges in clinical diagnosis of late life depression, particularly first of all, overlap of depressive symptoms with other features of aging. Considering neurovegetative shifts of aging, we know that older persons need far less sleep than when they were younger, sometimes only 4 to 5 hours, that their sleep routines are sometimes quite disturbed. They may sleep fragments of sleep during the night and fragments of sleep during the day. They also may eat far less and in far frequent amounts than when they were earlier or younger. There are also cognitive changes that occur in older persons. It might be a normal part of aging to have lower concentration. Older people tend to think about dying and the ends of their life much more than when they were younger. And these can be prominent in the picture of somebody with late life depression or even in normal individuals. There's this entity called pseudo-dementia, and I'll come back to that in a second. But what we're referring to are persons with significant major depressive disorder who have prominent cognitive features and may perform quite poorly on cognitive testing, so that the unsuspecting clinician may in fact diagnose dementia. But when you treat these individuals for depression, in large part the cognitive symptoms would resolve. And then of course many elderly use multiple medications, commonly known as polypharmacy, some of which may in fact complicate or precipitate depressive conditions, and you should always know about that. And then of course the entity known as somatization is very common in older persons. So they may more often complain of body aches and pains. They may complain of gastrointestinal disturbances. They may complain of inactivity or strange body sensations. And these may all be clues or red flags as to the presence of major depressive disorder. Regarding the diagnosis of late life depression, we do rely on the DSM-5 criteria due to its wide evidence base. Remember that the DSM-5 utilizes a syndromic approach to make exclusionary diagnoses. So you either have MDD or minor depressive disorder or dysthymic disorder or depression due to another medical condition or complicated bereavement. We do think, though, that in the real world it's possible that different components of these factors may be at play, so that somebody may have a true major depressive disorder syndrome, which is complicated by the presence of a medical condition, which is contributed to by the presence of medication, and that neither one nor the other factor contributes more or is the majority of the causation. So just a caveat on the use of the DSM-5 approach, but of course you must know this for exam purposes and utilize the DSM-5 approach. Some of the other features which may not be part of the DSM-5 include somatic changes that I've mentioned, pain symptoms, overlap with medical comorbidity, hypercortisolemia, increased abdominal fat, decreased bone density, and an increased risk for type 2 diabetes and hypertension. And then, of course, prominent cognitive changes may occur in late life depression, not so much specified within the DSM-5 criteria, although we do have psychological cognitive changes. It's not commonly referred to in terms of neuropsychological function. And then briefly regarding clinical assessment, you clearly want to know whether this is a recurrent condition whether there's a family history and whether stressors are present. You need to know everything about their general medical and neurologic history, obtain a list of current medications, understand the course of their illness and whether or not cognitive symptoms are present. You need to confirm the psychiatric syndrome. You need to conduct bedside neuropsychological or cognitive testing. The MOCA is useful because it will give you much more information regarding executive functions and other cortical functions than does the mini mental state examination. And then always do a brief physical if you can, looking specifically for pyramidal and extrapyramidal motor features. And then investigations that are commonly done include bloods that may contribute to the development or perpetuation of late life depression. A CT scan of the brain is often advisable, particularly if this is a first episode, although MRI of the brain will definitely give you more information about the subcortex and the white matter. If your patient is a smoker, do consider a chest x-ray or have a low threshold for doing a chest x-ray. And in a female patient who has non-specific abdominal symptoms, you'd be well advised to consider doing an abdominal ultrasound. I've pasted in here for you the geriatric depression scale, which is sometimes used by clinicians as a guide to eliciting a broad spectrum of depressive symptoms in older persons, also to track recovery and change over time, otherwise known as response or remission, but also can give you some idea of the severity in terms of mild to moderate to severe disease. This article by Pridgeson and Jacobs suggests the possibility that there are 4 types of depression. I find this quite convenient to try and see which category a person more likely fits into. And of course, it's never clean. In clinical psychiatry, patients may reside in 1 or more categories. But the first group are those with recurrent major depressive disorder, or perhaps first episode major depressive disorder in the context of significant life stressors. So these are people that you think most likely have, if for want of a better word, simple major depressive disorder. Then there's a group of people who have dementia plus depression, and we now know that if you have dementia, that you have a very high risk of having major depressive disorder in the region of 10 to 20%. There's an entity known as vascular depression, people with demonstrated vascular brain disease either on clinical features or on radiological findings, and I'll say more about that just now. And then people with comorbid medical conditions, which might be ischemic heart disease or cerebrovascular disease or Parkinson's disease or cancer or other chronic illnesses. And these people have a very, very high major depressive disorder comorbidity. Some of the medical comorbidities to consider include systemic viral infections, not necessarily central nervous system ones, endocrine changes, particularly hypothyroidism in older women, parathyroid syndromes, they do occur, and adrenal lesions, the cancers which occur obviously as you get older, cerebrovascular disease, myocardial infarction, then metabolic diseases. B12 and folate are very important, and alcohol use and misuse is also very common and something to look for. There's a long list of medications which, as I said, may precipitate or perpetuate major depressive disorder, so do think about these. Don't forget about over-the-counter medications, which are very, very commonly taken by older persons. Then we're talking about depression and dementia, otherwise known in DSM-5 as major neurocognitive disorder. We know that major depression is highly prevalent in Alzheimer's disease and possibly more prevalent in subcortical dementias such as Parkinson's or Parkinson's plus syndromes. There's a school of thought which suggests that persons who develop major depressive disorder in early or midlife may be at increased risk for the development of Alzheimer's disease, or in fact whether this major depressive disorder or episode is a prodrome of Alzheimer's disease. I mentioned before that some cognitive disorders improve after treatment for depression, which we call pseudodementia, but these people have a very high risk of developing subsequent dementia, with about 40% dementing at 3 years. And then there's some way to understand cognitive disorders in the context of depression. There's MDD with a primary dysexecutive syndrome, in other words, people who have dysexecutive features really with few other cortical brain features. By that we mean dysphasia, agnosias, and apraxias. And sometimes it's convenient to understand dysfunction of frontostriatal networks in the development of major depressive disorder and dysexecutive syndromes. So, for example, in dopamine dysregulation, as occurs in Parkinson's disease, similarly acetylcholine, and then opioids, which is a periaqueductal gray matter neurotransmitter. Then there's the entity of the vascular depression. These are people, as I said, with demonstrated vascular brain disease. They've either had a clinical stroke or radiological lesions, and they have some cortical features associated with the stroke, and then this entity of vascular depression, which is commonly associated with apathetic states and executive dysfunction. And then the true major depressive disorder with dementia, and by that we mean a progressive cognitive syndrome affecting two domains, usually including memory and other domains, and in which people develop major depressive disorder. So those three syndromes may be one way to understand syndromes of depression in the context of some kind of cognitive disorder. So in this slide I've pasted in for you a table which compares the differences between individuals with dementia and those with depression and cognitive impairment, otherwise known as pseudo-dementia. It's worth reading through all of the features, but in summary, persons with dementia generally have a gradual decline in cognitive function, which is stable over weeks to months, so that if you test them between months 1 and months 3, there'll be minor changes. The pattern of impairment will be fairly consistent, whereas those with pseudo-dementia will often perform poorly across different domains, so a scattered pattern. It may vary over time in the early phases, and also will obviously improve if you treat them. And typically these people with pseudo-dementia give very poor effort and will often say, I can't do this test, or it's too difficult for me, as opposed to the demented patient with depression will often just simply be unable to perform the task that you're giving to them. So one of the problems, as I said, is that there's often overlap. And so in order to try and diagnose somebody with purely major depressive disorder who hasn't had an early life episode, you're really wanting to exclude underlying vasculopathy, exclude contributory medical comorbidity. The problem is many of these people have medical comorbidities, and so it's up to your clinical judgment to decide to what extent the medical condition is contributing to the late life depression. And then you need to exclude the presence of a significant cognitive disorder, whether or not the depression in front of you is in fact being precipitated by a dementia or is a prodrome of an incipient dementia about to manifest itself. The vascular depression is something that is commonly encountered. These are patients with white and deep gray matter changes that are associated with depression. Typically, they have had either clinical stroke or radiological evidence of stroke, and will develop a depressive condition or depressive syndrome in the light of that and following that. Some of the definitions applied include not only the clinical history of stroke with neurologic features of upper motor neuron disease such as brisk reflexes or pseudobulbar palsy, but on scanning, particularly MRI scanning, there are at least 2 lesions or a single lesion that's bigger than 5 millimeters. And again, the problem is in older persons who've had brain imaging, we commonly see periventricular white matter change, which is a very non-specific finding in old age. And we commonly see non-specific white matter hyperintensities. And so it becomes, again, a matter of clinical judgment of whether or not you think the depressive syndrome is being caused by the MRI picture that you see, and weighing up in your mind the burden, the pathological burden of these lesions. A diagnosis of vascular depression would be supported by an age of onset over the age of 50. In other words, these are people without the hereditary loading that I mentioned, or they've had vascular brain disease earlier on in life, and of course depression could follow that. They have a marked loss of interest or pleasure, otherwise known as anhedonia, but possibly also linked to that anterior cingulate cortex, cingulate cortex, or subcortical circuitry. Marked psychomotor retardation, which is a subcortical feature of brain function. A lack of family history, which again is the hereditary factor, and diminished activities of daily living, which suggest an underlying executive dysfunction. So this is a model that I've extracted from a journal called Molecular Psychiatry, which just puts into some kind of pictorial form what the vascular depression hypothesis looks like in persons with underlying vascular risk factors and vascular disease outside the brain. They may develop stroke lesions, which disrupts fiber tracts and circuits, leads to altered functional connectivity in the brain. As I said before, hypometabolism of the dorsal neocortical structures and hypermetabolism of the limbic structures, altered regional brain function, ultimately leading to depression. There are some treatment implications, and one might think that these are somewhat logical, that people with established brain disease and fiber tract disruption might find it difficult to sustain remission. They might respond more poorly to antidepressants, and in fact there's some evidence to suggest a poorer response to SSRIs and the drug nortriptyline, a tendency to early relapse and recurrence, a tendency to respond better to problem-solving therapy than supportive therapy. And again, this is somewhat logical, because if a person has got organic brain disease, a loss of executive function, then they will not be able to solve problems on their own, and they would be better off when others assist them to solve problems or provide them with routine and structure and mechanisms to solve those problems. There's some evidence from primary healthcare that in people with executive dysfunction, they respond better to depression care management, which is really a much more structured approach to management, with case management, regular follow-up, psychoeducation, caregiver involvement, than routine care or standard of care. I want to just spend a minute or two talking about suicide in the elderly. This is a very important phenomenon which occurs more commonly in the context of depression in older persons than in younger persons. Rates of suicide in the elderly are higher than in the general population. There are demographic features which one has to look for, and I'll show you a table now which will highlight that. If you're older and you attempt suicide, you're more likely to die as opposed to if you're younger. As I said, if you're depressed and older, there's a tendency for suicidality to occur in the context of depression more likely than in younger people. There are associations with loss of social connection and with certain personality features, which I've mentioned earlier in the model of late life depression. The presence of firearms or availability of firearms doubles the risk of suicide in elderly people, and this is a common route to suicide. So while suicidal ideation may decrease with aging, if they do have suicidal ideation, this is often not transitory, and they are at high risk of committing suicide. So one must always ask about it when you're assessing an older person. And these are some of the risk and predictive factors that you may be aware of, just to point them out. Older white males who are lonely and alone, who've been widowed or divorced, unemployed, disconnected, life has got no meaning. They have multiple medical comorbidities which cause pain or distress. There is substance abusing. There's a history of suicide. There are some compensatory factors. People who have a history of being able to adjust to change over time, either through work changes or environmental changes or relationship changes. And you can ask them about this when you say, when you retired, how did you cope with that? What did you do? How did you feel for the 6 months afterwards? And you would get a good sense of whether or not this person has got an adaptive or resilient brain. As I said in that model, they can cope with the allostatic changes associated with stress. The NICE guidelines will give you a good starting point to think about treatment issues. So when they refer to older persons with depression, there is some important considerations. Firstly, that bleeding is more common with SSRIs in older persons. One needs to take the comorbidity into account and use age-appropriate doses, certainly at treatment initiation. There are risks associated with ECT, primarily cognitive risks, but also some anesthetic risks, although it's not absolutely contraindicated. When you're considering maintenance therapy beyond 2 years, you need to reevaluate the syndrome, taking into account age, comorbidity, and other risk factors, because any medications in older persons are associated with high risk of side effects and adverse events. And then, of course, one has to consider key side effect issues in drugs like miancerin. You might need to monitor the white cell count, although these days we use miancerin a lot less than before. Some other issues to consider, which I'll highlight shortly. At older persons may take up to 3 months to reach optimal improvement with an antidepressant, and this is probably a combination of starting at lower doses and increasing more slowly, but also the fact that the older brain takes time to develop neuroplastic changes that are associated with recovery. The natural history of depression can be as long as 3 years or longer. Long-term treatment might be effective for up to 3 years. Depression is more likely to relapse. In the context of dementia, obviously we need to avoid drugs with anticholinergic side effects. This is mainly the tricyclic class, but there are other drugs that have some intrinsic anticholinergic properties. The need for adherence, and this by inference means supervised treatment in people who struggle to remember to take their drugs. The time to onset of action and the risk of withdrawal effects should be explained at the start of treatment. So we do know that some of these drugs, SSRIs, venlafaxine, have discontinuation symptoms, and you need to explain this to both patients and caregivers. So principles of the treatment are to first remove offending illnesses, medications, and environments, to strongly consider psychotherapy, which might be sparing of the use of drugs or might be an important augmenting strategy. When selecting your antidepressant, build from a lower base, but then allow time for effect. And I'll illustrate that just now in the next slide. And then select your drug based on the evidence for the medication, if the person has taken it before and responded, if there's comorbidity, or in fact other symptoms which you will try and treat, and I'll refer to that shortly as well. And then ECT is not contraindicated. So in this forest plot of a collection of studies of SSRIs, in the top half you'll notice a spread of drugs: escitalopram, fluoxetine, duloxetine, venlafaxine, over a treatment period of 6 to 8 weeks. And in those trials, only 3 of them, so less than half of those trials, achieved significant difference between treatment versus control condition. And so the overall meta-analytic outcome is to favor the treatment, but many of the studies show equivalence with control. Whereas if you look at the lower half of the forest plot, you'll notice for similar drug trials, escitalopram, paroxetine, and bupropion, these are longer studies, 10 to 12 weeks, and you'll notice all but one of these trials indicates that treatment favors placebo and a much higher effect size for the meta-analysis of those studies. And these data suggest that longer is better and that it takes time up to 12 weeks for us to see a robust treatment response in older persons. And one of the challenges of drug trials, not only in older persons, but also in fact in younger persons, is the conflict of interest of investigators. In fact, if you look at all those studies that I just showed you and look at the conflict of interest section, you'll notice many of these authors have got affiliations to drug companies or have received honoraria from them. So one has to always interpret these with a great deal of circumspection. In this table, what I show you are placebo-controlled trials of late-life depression. So you have the example on the far left, fluoxetine versus placebo, venlafaxine, fluoxetine, and placebo in a 3-arm trial, sertraline versus placebo, citalopram versus placebo, etc. Reasonably sized trials, persons older than 65 and 70 in most instances, more than half of them are women, at reasonable doses, and then trial lengths ranging from 6 to 8 to 12 weeks. And what I want to point out to you, first of all, are baseline Hamilton Depression Rating Scale scores. You needed 20 to enter those trials. So these are moderate to severely depressed individuals. And then to point out the percent response rate between the active drug and the placebo agent. And in fact, for all but one of these trials, at the top, the fluoxetine response of 42% versus placebo of 30% was significantly different. But for all the others, there was a significant placebo response rate over the trial period. When you look at antidepressant comparison trials, so in these studies, it was then considered unethical to give moderately depressed individuals placebo drug. And in fact, that may be the case nowadays, that you would not be able to conduct those kinds of trials. You'll see head-to-head trials, average age of persons very similar, again, about 2/3 women. Some of these longer trials, the baseline Hamilton Depression Rating Scale scores may be slightly higher, so moderate to severely depressed individuals. But then you'll notice the percent response rates in those studies in which it's listed, way more than 65% across both arms of these studies. So there's significant placebo response effect, and for persons who enter head-to-head trials, they're told you will receive one or other active agent. And so the effect of expectation of recovery plays an enormous part in antidepressant treatment, and one mustn't forget that. Looking through some of the antidepressants, when you look at the SSRIs, they're all shown to be effective. There are class effects. I mentioned bleeding. Don't forget hyponatremia, which does occur in older persons to some extent. And then inhibition of the cytochrome P450 enzymes with some sparing of that effect for citalopram and escitalopram. A bunch of other antidepressants are available to you. They're all used in older persons. Mirtazapine, notably useful for people with sleep disturbance, but it does cause weight gain. Venlafaxine, very useful for anxious patients, but it does cause hypertension, and that needs to be monitored. Bupropion, supposedly useful for people with apathetic syndromes, but it does produce insomnia and may increase the risk of seizures. We tend not to use the older tricyclic drugs very much, nor mianserin. And then one of the newer antidepressants, vortioxetine, has been thought to be associated with a pro-cognitive effect, in persons with depression and cognitive impairment, so you may consider trying that drug as well. This is a slide just to assist you considering which antidepressant to choose based on the depressive phenotype that you may see. In persons with cognitive symptoms, you might consider SSRIs, SNRIs, or vortioxetine. With agitation or agitation or aggression, similar choice of drugs, but you may want to add an atypical antipsychotic at low dose to manage agitation and aggression. For those with apathy and energy, again, SSRIs or bupropion, or in some cases methylphenidate for short-term use might be useful. For people with insomnia, you might consider mirtazapine or triptyline, or an SSRI with a sedative atypical antipsychotic such as quetiapine. For those with marked anxiety features, I find paroxetine useful, one of the SNRIs, or mirtazapine. For pain syndromes, duloxetine is commonly used, or low-dose tricyclics, or otherwise an antidepressant with pregabalin, otherwise known as Lyrica. And then you do get people who have appetite issues and have lost a lot of weight, and these drugs listed below would definitely increase or stimulate the appetite: mirtazapine, paroxetine, or an SSRI with an atypical antipsychotic. For some individuals who respond poorly, you might want to augment them with bupropion in the morning with lithium, and there's quite good evidence for lithium usage in older persons, provided that there are no contraindications. You could add olanzapine, 10 milligrams at night, or offer combination therapy, an SSRI or venlafaxine, plus mianserin or mirtazapine at night. And you may consider referral to a subspecialist old age psychiatrist or neuropsychiatrist for further treatment. There are some psychosocial interventions that you might consider in terms of the evidence base. Problem-solving therapy I mentioned to you, being able to teach patients skills for improving their ability to deal with everyday problems and crises. And these therapists would really want to take a very practical, pragmatic approach to assist patients in solving problems that they find otherwise overwhelming. We know that there's a good evidence base for cognitive therapy and cognitive behavioral therapy for persons who are suitable for that. And then there are other therapies which are aimed at collaborative care programs, a combination of drug treatment as well as problem solving and motivational approaches, and helping older persons deal with challenges that they face. In terms of Patrick, who's the patient I mentioned at the beginning of the talk, we treated him with a combination of venlafaxine and lithium therapy. We provided some degree of problem solving, and over the 2-month period, he gradually improved, his weight normalized, and he became euthymic. We were able to discharge him. So these are the take-home messages. You need to conduct a careful assessment with attention to comorbidity, particularly medical and neurologic comorbidity. Your prescription needs to be very, very careful, with careful attention to adverse effects and any drug-drug interactions. You need to persist with treatment beyond 8 weeks, and remember that patients with depression in late life may in fact have quite long-lasting illness. And I would suggest that you become confident in using 2 or 3 or 4 drugs, which you can select according to patient profile from the SSRI class, from the SNRI class, and from one of the other classes of more sedating drugs, and use them in your practice.